Welcome, everyone. My name is Gabrielle Sedor, and I'm the Chief Operations Officer and the Foundation Director here at Anchor, the American Network for Community Options and Resources. We are a large national nonprofit association for providers of IDD services and supports. And I'm absolutely delighted to have been asked to welcome our gold partner, MediSked, today to present to you their presentation on the 6 pillars. CMS is now structuring its innovations and policy directions into 6 pillars. The 6 pillars hold together the overall goal of CMS for this administration, which is to foster a U.S. healthcare system that's better, smarter, healthier, to improve care, spend healthcare dollars more wisely, and make our communities healthier. In today's webinar, industry experts JoAnn Lamphere and Doug will discuss CMS's vision, the role that we can play within this framework, and how CMS, states, providers, and MCOs can collaborate and share accountability for achieving discernible improvement in healthcare outcomes, and more importantly, quality of life for individuals. Dr. JoAnn Lamphere is a consultant for MediSked, but she previously served as the former Deputy Commissioner of Person-Centered Supports in the New York State Office of People with Developmental Disabilities, until she retired in 2018. Her previous roles include serving as a former principal at HMA, Health Management Associates, and as the State Government Affairs Director for the Long-Term Care Team at AARP. JoAnn earned her doctorate in public health at Columbia University. Doug Golub is the president and co-founder of MediSked and focuses HCBS policy expertise and passion into delivering innovative technology solutions to healthcare and human services. Doug sits on the Anchor Foundation Board of Directors, and he's currently very ably serving as our board treasurer. And for that, I am thankful. Prior to joining MediSked, Doug served as Platform Services Manager for Microsoft's Health Solutions Group. Doug holds a Master's of Information from Rochester Institute of Technology. And with that, today's subject matter experts. Welcome, JoAnn. Welcome, Doug.
Thank you, Gab.
Thank you. Good afternoon. I'm delighted to be with you to explore a new way of thinking and acting upon the healthcare forces that challenge our lives. Many of us are reeling from the pandemic, the economy, and George Floyd experiences of the past 2.5 years. As Bob Dylan aptly noted, the times they are a-changing. The Centers for Medicare and Medicaid Services, that is CMS, has grasped the force of these changes and has put forth a clear framework for action and policy direction for these times. Our purpose today is to identify the pillars of this framework and to see how they apply to our efforts to advance the nation's health and improve healthcare. What are the 6 pillars? They include 1, to advance health equity by addressing the health disparities that underlie our healthcare system. 2, to build on the Affordable Care Act and expand access to quality, affordable health coverage and care. 3, engage our partners and the communities we serve through the policymaking and implementation process. 4, drive innovation to tackle our health system challenges and promote value-based, person-centered care. 5, protect our program's sustainability for future generations by serving as a responsible steward of public funds. 6, foster a positive and inclusive workplace and workforce and promote excellence in all aspects of CMS's operations. Now, why are these 6 pillars important? Together, they hold together the overall goal of CMS, which we just identified as fostering a health system that's better, smarter, and healthier, improving care, spending health dollars more wisely, and making our communities healthier. The pillars provide a coherent structure and a communication tool for engaging CMS's state and provider partners. They organize the thousands of old and new federal policies and programs into a coherent framework for action and priority setting. They align financing and regulatory tools to advance the national objectives so that these regulatory tools don't work against each other as we try to accomplish a mission. They help us make sense of new policy developments. By far, the most important pillar is to advance health equity by addressing the health disparities that underlie our healthcare system. It has long been recognized that healthcare in the United States is inequitable. Health equity means providing care that doesn't vary in quality or quantity because of personal characteristics such as gender, race, disability, geographic location, and socioeconomic status. To increase equity, CMS is looking to do many things, and they include identifying and disseminating promising approaches to reducing health disparities across many populations, increasing the ability of the healthcare workforce to meet the needs of vulnerable populations, understanding their needs, and developing culturally appropriate interventions, expanding standardized data collection, reporting, and analysis to pinpoint disparities and to track improvement, and also to increase the physical accessibility of healthcare facilities, an important objective for many of the populations we serve. The federal government advances health equity in the Medicare and Medicaid programs in many ways. In Medicare, equity strategies include implementing payment policies in traditional Medicare, such as value-based payments and accountable care structures. CMS is looking to embed these innovations, value-based payments and accountable care, with more consideration about equity, and they want to accelerate implementation of these ideas. For Medicare Advantage, which is managed care, enhanced quality measures are being considered to account for some social risk factors that impede equity in care. The Medicaid program that is administered by state governments can also be an important force to advance health equity. Eligibility and payment policies are key to improving equity. There are other strategies as well. Reviewing provider network compositions and reimbursement to determine areas that are underserved. Utilization management. Do plan policies impede necessary care for people with chronic conditions or intellectual and physical disabilities? Managed care procurement process also offers opportunities. States can require equity plans in contracting with managed care. They can target movement towards a better, improved chronic disease management. And they can alter payment mechanisms to expand provider networks in underserved neighborhoods. They can include communities of color and voices that are not typically being heard in program development. The goal of advancing health equity has been embraced by national organizations and healthcare providers, and not as an afterthought. Major healthcare providers and plans and their national associations are being driven to ensure that improved health equity becomes part of their core mission and embedded in decision-making across the board. For example, health equity officers are being hired by many providers to pull together and coordinate the important equity work underway in their organizations. And senior staff performance is being reviewed, as they must now show equity is at the heart of everything they do.
Thank you, JoAnn. For today's presentation, as you probably gathered from the title, we'll be reviewing these 6 pillars one by one, providing the context and the policy decisions behind them, but also tying it back to the home and community-based services world and the very specific strategies and tactics that we've seen. We'll be using an application of data analysis to improve individual well-being and performance. And the work that MediSked does and the data that we're able to show comes from our mission to improve lives, drive efficiencies, and generate innovations for health and human service organizations that support our community. So at the end of each of these pillars, we'll go back to a recent presentation and recent data finding, data stories from MediSked to give some very specific strategies, tactics, and data to tie these 6 pillars to the world of home and communities services and long-term services and supports. And so for the first on equity, we tie it back to a presentation from just this past week. One of our longtime partners, AARP Nassau and the AARP of the United States, put on a diversity, equity, and inclusion conference just this past week that could not be more timely. In that presentation, and there are QR codes if you want to see these presentations in more details, we'll also in the materials have links to all of them. Some really interesting information that we were able to find that helps us to know what we know and know what we don't know to chart forward. We found some data from the Journal of Developmental and Behavioral Pediatrics, and what we found, looking in North Carolina as one example, although there's an example in every state, only 22% of the 53,531 individuals with intellectual and developmental disabilities in that state received the waiver. And when you look by race and ethnicity, what you find is about 56.6% of eligible white non-Hispanic individuals received the waiver, 29.3% of Black non-Hispanic individuals, 11.9% includes other, which for the purpose of this study was grouped together, and it groups many, many, many people. And 1.9% of Hispanic white individuals received the waiver that were eligible. Only 0.2% of Hispanic Black individuals that received the waiver that were eligible. And so what you can see here is there are definitely differences for those individuals by racial and ethnic groups with equity. In addition, AARP Nassau allowed us to use some of their actual employee data, studying over 3,000 staff members over a 10-year period. And what we found is not uncommon, but there's the difference between knowing versus feeling. And this allows us to know what we see again and again in our people that are supporting the people that we support. 100% of the individuals supported by AARP Nassau have an intellectual and developmental disability, making them part of a historically marginalized community. In addition to that, the direct care staff, by race alone, about 16.5% of the direct care staff are white, and 84.5% of the direct care staff are Black, Indigenous, and people of color, or BIPOC. Further, the direct care staff are about 77.8% female, identifying as female, 22.2% identifying as male. And so when you look at these groups, these are all historically marginalized populations, communities that are on the staff side and on the individual side exactly why we're here, the work that we do at MediSked and the tie-in that we make to these 6 pillars. So this moment could not be more appropriate, and advancing health equity is incredibly important to those that we support and those that support those individuals. And so we'll continue to show some of the data and tie-ins as we go through the other pillars from this administration's strategy. And the next pillar is access.
The second pillar is to build on the Affordable Care Act and expand access to quality, affordable health coverage and care. The Biden administration's strategy for expanding affordable coverage is to build on the Affordable Care Act of 2010 and not replace it. In fact, more than 21 million people now are covered through the ACA, and millions more have protections with their pre-existing conditions. CMS is continually reviewing Medicare and Medicaid and marketplace coverage to determine how better and more affordable health coverage can be generated through existing tools and approaches. Still, some individuals remain vulnerable and without health coverage protection because they cannot afford private plans and don't meet eligibility criteria for Medicaid. The important lesson of the ACA is that if health coverage is made more affordable and people learn about affordable options, individuals and families will sign up and enroll. A record-breaking 14.5 million people signed up for coverage in 2022 through the ACA marketplaces. And this year, there's been a 23% drop in the average monthly premium in marketplace coverage. The American Rescue Plan lowered health care premiums for most marketplace consumers. And the insurance rate in the United States has plummeted. It is now an estimated 8.9% of the population. For many of you and our friends with disabilities, it is HCBS, that is home and community-based services, that present the biggest affordability challenge. The American Rescue Plan of 2021 included a provision to increase the federal matching rate, that's FMAP, to states for their spending on HCBS. And CMS recently announced it will offer more than $110 million to further expand HCBS through Medicaid's Money Follows the Person program. Our advocacy work is not done. Long-term services and supports, primarily funded by families out of pocket and by Medicaid, must remain an important part of society's focus in addressing the overall cost of healthcare.
Thanks. I see we have several folks from InterHab in Kansas and also from some of our Developmental Disabilities Organization, DDO friends. Welcome. This conversation about access actually includes some data from our recent InterHab presentation in Kansas. And this is a case study showing how through systems interoperability and workflows, we can increase capacity, accuracy, and timeliness of enrollment and keeping people connected to care and to supports. And so two specific examples, working with CAMIS, the data interface, having data demographic and assessment information entered into CAMIS and formatted and loaded directly into the MediSked coordinate system that helps care managers to be able to have the information that they need to expand the scope of what they can do and connect people more quickly and more accurately and keep people connected to services and supports, which is really important for access to quality and affordable care. And the interface with KMAP on the eligibility side with the alerting behind that absolutely helped to make sure those electronic data interchanges keep people up to date so that people are quickly connected to the correct services and supports and stay connected. And so thank you, InterHab, for allowing us to showcase that. And thank you, Kansas, for joining today. We have one other case study on specific strategic strategies and tactics in practice for expanding access. And that's in North Carolina. And last December at the Eye to Eye conference, we had an opportunity to work with our partner, the AARP of North Carolina, to look at some differences between urban and rural counties. And about 70% of the counties are designated as urban, about 30% as rural for the people that are supported. We studied 2,662 individuals in the Community Navigator program across North Carolina. And what we found here, what these two graphs are showing you, on the left, these are people living in urban counties, making up about 70%. These are people on the right living in rural counties, making up about 30%, as designated by the census. And what you see here on the left is that in 2018, 2019, typically in more urban counties, specifically the Community Navigator service, which is a service to connect people to be able to access quality and affordable care, was generally 50-50, if not a little bit more in person than it was virtual. Well, something happened in March of 2020. The public health emergency started, and the graph could not be more clear. These services increased to being virtual by a margin of 82% to 18%, and basically have stayed that way ever since. And so in more rural communities, because of the challenges of distance to go out and see people, phone calls, Skype meetings, FaceTime meetings, Zoom meetings like this, those have always been a bit more prevalent in rural communities because of the challenges of access. And what we see here is, well, lots happened since 2020. Technologies have come a long way, and our adoption of technologies have come a long way. And as you see the graph on the left and on the right, the spread is pretty even between urban counties and rural counties. People are able to think in a more technology-first way, which expands access to quality and affordable care, in this specific example, between urban and rural individuals, but it goes on from there. So we wanted to share some of this data, some of these data elements here, and the QR code is here, the link is later to get some more information about expanding access to quality and affordable care through the use of teleservices as a specific strategy and or tactic in practice. And our third pillar is engagement.
As Doug said, the third pillar is partnership engagement. The nation's healthcare challenges are too great, too urgent for any one organization to tackle alone. Partnerships are essential to achieving our nation's vision of a healthier population and reduced illness burden across urban and rural communities. More collaboration is essential among healthcare delivery organizations, community-based organizations, health plans, government agencies, and consumers to reduce disparities and increase health and well-being. Multi-sector collaboration among stakeholders and partners, if well organized, can substantially increase the health of communities that are served. We have learned this to be true. And sustained attention and additional resources must be allocated to build the capacity of health organizations to work together better. For many dedicated people who deliver healthcare, it can be unnerving to realize that there are significant flaws in the traditional medical model of care. The traditional medical model is insufficient for maximizing Americans' health, given the documented social determinants of health that influence health and well-being and care-seeking behavior. You can see the picture on the right, what some of these social determinants of health include: education, economic stability, community context, neighborhood, and so forth.
Thanks, JoAnn. We're going to take a look at partnership engagement. A few pillars from now, we'll be taking a look at housing and other aspects of social determinants of health. But as we all know in the work that we do, partnerships with both paid and unpaid supports in the community, privately, and otherwise are absolutely critical to helping a person achieve the best life that they can and that they want. And so we have a diagram here that shows some of the different kinds of supports that are available to a person, of course, with the person at the center. And whole person supports are really about community-based, person-centered supports and physical health coming together. So as we look at what's available from social service agencies, religious organizations, schools, public health, primary care, hospitals, specialty care, community programs, understanding all of those supports that are available and how they fit into the social determinants of health and overall whole health for a person are critical. For this particular presentation given at AADMD, the American Academy of Developmental Medicine and Dentistry, we work with a payer client of ours to help identify people that were high utilizers of emergency rooms or emergency departments, and helping to look, especially for a very vulnerable population, at those individuals that perhaps were not always using these ED visits for medical purposes. Perhaps there were situations where these EDs were used for shelter, for food, for escape from domestic abuse, and for other non-medical reasons. And working with our partners and working with these other partners in the community, our clients have been able to look at claims data patterns, care manager note narratives, and a process of weekly rounds that have connected people to supports that might be more appropriate and better for the person than an emergency department or an emergency room, which has saved lives and reduced costs. So partnership engagement is critical in many ways. Here are some examples that are some of the most striking, and we'll get to some additional throughout the course of today's webinar. With that, the next pillar is driving innovation.
Driving innovation is the fourth pillar. Innovation is where the rubber meets the road and is often under-recognized as a key to achieving the other pillars. Designing and implementing new care delivery and payment methods is the responsibility of CMS's Innovation Center, known as CMMI, the Center for Medicare and Medicaid Innovation. CMMI was established under the Affordable Care Act and has launched scores of demonstrations to test new delivery and payment system methods. CMMI is focusing more on equity now and paying for healthcare based on value to the patient, the person, instead of volume, and delivering person-centered care. CMMI focuses on Medicare a lot, as Medicare accounts for 1/5 of all US healthcare expenditures, and it influences how other payers will behave. CMS is trying to give providers incentives and tools to deliver high-quality, coordinated, and team-based care and reduce low-value services. Perhaps the best-known innovation among participants in this webinar is the fully integrated Duals Advantage Plan for adults with intellectual and developmental disabilities. What a mouthful. That's why we call it FIDA-IDD. It was initiated in 2015 by CMS's Innovation Center in partnership with New York State and Partners Health Plan. The FIDA-IDD is a joint Medicare and Medicaid initiative designed to test new integrated model of care for providing dual enrollees, that is, they have both Medicare and Medicaid, with a more coordinated, person-centered experience. Doug?
Thanks, JoAnn. And MediSked was honored to be part of getting this off the ground and breaking some of the barriers to providing supports in this integrated way through some of the technology tools, from assessments that automatically identify goals, supports, and tasks for a person, through a care management platform that helps assign those tasks and activities to the care manager, to the individuals, to staff at various providers, to other paid and unpaid supports, and creating a feedback loop to make sure that the person's supports are no longer siloed and are brought together in a way with reporting. This has been used throughout other states across the country, used in a health home model as part of Section 2703 of the Affordable Care Act that adapted some of the work that Partners Health Plan made possible, storing over 2,000 data points on every individual and being able to identify those to work with a care manager with a dashboard to help with preventative care screenings, tests completed as recommended, clinical practice guidelines, help to identify gaps in care and the need for additional screenings and other components that help with overall physical health and goals, supports, and dreams, whether it is residential settings or employment options or transportation or food. This innovation really helps to create what was really one of the first to be able to do this. And minimizing readmissions is something that PHP has been extremely successful with because of the ability to identify the data by the right people and be in touch, and that person-centered, person touch has made it possible. And that data-driven decision-making that is part of the care coordination suite. This was among one of the first, and it has been rolled out in many places across the country. And we always appreciate when states go to look at what PHP has done and glean from that to continue to drive innovation. And we've come very far. There's so much more to go when it comes to innovation and continuing to support people in the best way possible. And that actually ties in very nicely to one of the major reasons for innovation, which is program sustainability, in addition to supporting people to live their best lives and have their best health outcomes.
So the fifth pillar is to protect our program's sustainability for future generations by serving as a responsible steward of public funds. Healthcare spending in the United States is massive and has been an ongoing concern for decades. This fifth pillar captures the challenge and makes a commitment to future generations. We have to manage these programs so they will be around for the future. If you look at the diagram, the US healthcare spending now in 2021, the latest year where estimates are available, US spending exceeds $4.3 trillion. It's 19.7% of the United States gross domestic product. It is a very big deal. And so when we think about protecting program sustainability, I should mention the term cost control is no longer in favor. And clumsy and poorly targeted reimbursement approaches to reduced growth in healthcare spending are being replaced by new approaches. And these new favored approaches include value-based payments, clinical and community care process improvements, market competition, and transparency. CMS is committed to assuring Medicare's sustainability in several ways, increasing transparency in both Medicare Advantage and traditional Medicare, improving Medicare claims processing and payment accuracy, and reducing fraud, waste, and abuse. Transparency is currently a big deal. Two policies were enacted in the past couple of years, despite provider and health plan consternation. The first is the Hospital Transparency Rule, which requires health systems to publicly post the price of their items and services online. This started in January 2021. And beginning in July 2022, most health plans and health insurers will be required to post price information for covered items and services. This transparency helps consumers to shop and to compare prices across plans and hospitals and estimate the cost of care before going to the hospital or choosing a health plan.
And so two of the tie-ins to protecting sustainability on the home and community-based services world, we take a look at the final home and community-based services settings rule. It maximizes opportunities for people to have access to the benefits of community living and receive services in the most integrated way. And in doing so, we had a chance to study a population of about 25,000 individuals. And through consistent assessment and data tracking tools, help to find those people that were looking to live in a different kind of a setting that they lived in. Through assessment tools, were identified that probably could be, through a qualified care manager, identified as someone that could be unsupervised for a period of 8 hours or more. And from there, look at people that lived in the kind of a setting where there was availability to live somewhere that was more integrated than the setting that they were in. Exactly the spirit of the settings rule. This person wants to live in a more integrated setting and can live in a more integrated setting. And when we did that, we helped to identify a population of people that was basically through those moves and through the cost savings, where those cost savings for living in more integrated settings could be more than 50%, given the high costs of specifically congregate residential settings. So looking at a population that many of whom have moved since the study was done in 2019, saving in excess of $10.2 million a year. But it's not all about cost savings. That is a big part of sustainability, but as JoAnn mentioned, not the only part of it. For this particular group in 2019, 14.1% of people wanted to change where they lived. When we went back in 2020, the beginning of 2020, because we can't speak to what happened in the second half of 2020, about 12%, so 2.1% of people were reporting happier with where they were living. And so when it comes to sustainability, there's cost control, but there's much more to independent living than cost control, that's for sure. And what we saw, especially in 2020, in the time of COVID, individuals living in more integrated settings were more likely to avoid COVID infection and were more likely to recover when they were infected. And so here we can see that 22% of the people in our study, of the 25,708 people in our study, 22% lived in certified group homes larger than 4 beds or other roommates. 6% lived in certified group homes with 4 or fewer beds, and 72% of people did not. They lived on their own, they lived with a roommate, they lived with family, they lived with friends or other. And so in looking at that information here, we can see the breakdown, and we can also see some discrepancies, the gray bar. So for the people living in certified group homes, even though they were 22% of the population, they made up for 53% of the positive COVID cases during the first year of COVID. That was pretty significant. And when you look at, unfortunately, the negative outcomes, those that were deceased, and remember this was to the end of 2020, so there was no vaccine yet. In fact, in the beginning, there was hardly PPE or social distancing understanding at the beginning. So we're talking about really hitting this pandemic head on. And this particular group was in the New York City area, so they were the group to get hit the hardest in March, April, May of 2020, 2 years ago. It's clear from the data that we had the opportunity to review that people in more integrated settings were less likely to be infected. And obviously being infected was, we looked at a lot of other data around comorbidities. People in more certified group homes might have other medical conditions in the first place, but one thing we do know, you have to have COVID to die from COVID. So keeping infections lower was, no question about it, the single greatest way to survive COVID, and living in more integrated settings created less of a risk of having COVID. Now, this is not for everyone to be living all by themselves, but for those people for whom this makes sense, it's what they want, and it's a good option for that person. This is the focus of the study. There are many people that are very happy with where they are and will continue to be very happy with where they are. But we studied those people that were not happy and wanting to move to more integrated settings and could. Probably one of the more lower hanging fruits to study. But as you can see here, program sustainability involves every angle that you can find it at. Every person matters, and every opportunity to move the needle matters, especially when it's something life and death, and something that also looks at cost control and costs that could be up to 50% higher for living in certain settings. So just some tie-ins, and this presentation is available from the QR code or later on. And then we get to the next pillar, which is the final pillar, fostering inclusion and excellence.
The sixth and final pillar is to foster a positive and inclusive workplace and workforce and promote excellence in all aspects of CMS's operations. CMS pursues this pillar both directly and indirectly. CMS recruits and manages full-time personnel and procured contractors. There are about 6,000 employees of CMS. Also, CMS is responsible for workforce development policies and funding for training the nation's healthcare workforce. We forget how large the healthcare workforce is in the United States. The health sector is one of the largest and fastest growing sectors in the nation, employing over 22 million individuals, representing about 14% of the total workforce in 2019. The sector, however, is facing substantial shortages in many parts of the country, as well as severe clinical burnout. America will face a shortage of up to 124,000 physicians by 2033, it's been estimated. It's known that job vacancies for nursing personnel increased 30% between 2019 and 2020. There are huge unmet behavioral health needs, and it's become a crisis in many parts of the country. One estimate suggested an expected shortage of up to 3.2 million healthcare workers by 2026. And many providers of disability services are turning away new referrals and discontinuing programs and struggling to meet quality metrics because of a shortage of direct support professionals. This is a very serious situation with no firm solutions in sight.
Absolutely. Thanks, JoAnn. And I started my career as a direct support professional about 22 years ago. And back then, there were more people than there were jobs. Today, it seems as though there are more jobs than there are people. And that has not necessarily boded well for healthcare, especially for human services and long-term services and supports when it comes to inclusion and excellence. And so the next tie-in is taking a look at an opportunity we had to do a study in Illinois. And so our friend Amy Lulinski, who is on the call, invited us to come and speak at the AARP of Illinois Leadership Conference just this past February 2022, and take a look at some of the labor crisis that we're seeing right now. It looks very different than it did 22 years ago. It looks very different than it did 2 years ago. And it wasn't great 2 years ago. And so what we had a chance to study here, we studied some of our clients across the country by looking at their usage and staff members, and we had a chance to study those in Illinois. And we've had a chance since to do this in several other states and regions to try to look at patterns or try to find opportunities to look at bright spots. We're still looking. But what we find here is from 2019, 20, 21, the replacement rate, how quickly we can replace our staff when they go, direct support staff, has been decreasing, but it's still not great nationally. The workforce is shrinking. When we take a look at Illinois, it was higher than the national average, and the trend is trending in the opposite direction. What this tells us is that Illinois is doing a bit worse than the national average. What this also tells us is we're replacing an awful lot of staff, but we're also not replacing an awful lot of staff. And the numbers are getting to a point where organizations are turning away individuals, cutting services. The public health emergency has created a labor market that is extremely difficult, especially for home and community-based services to operate in. And through great advocacy through work like the AARP and through Anchor, if you take a look at this presentation, some great studies help us quantify exactly how severe this problem is. We see a situation where there's a reason that CMS has identified this as one of the pillars. There's a reason why they've identified each of the pillars, but this especially. What data can we use to help influence what we can do about this? Certainly wages always comes to the top of the list, the data to influence policymakers about the severity of the problem. For our staff, providing growth opportunities and making sure that our direct support staff have the opportunities to grow so they don't leave. Important recognition, right? We're not thanked every day for the work that we do, but it's so critical. And diversity, equity, and inclusion, making sure everyone feels comfortable in the workplace. So check out this presentation if you get a chance. It doesn't answer all the questions about what to do about the labor crisis, but it provides some data, strategies, and tactics to hopefully help us make the change together. And are appreciative that CMS has identified this as one of the major challenges, because we on this webinar certainly feel that every day.
So to sum up, the overall goal of CMS that is captured in the 6 pillars we've discussed is to foster a U.S. healthcare system that is better, smarter, and healthier, and to improve care, spend money more wisely, and make our communities healthier. As partners in national efforts to achieve access, equity, quality, and value in public spending, we must hold CMS and each other accountable as we seek to accomplish the nation's bold mission in the months and years ahead.
And we have some resources. MediSked is the leading brand in holistic solutions that improves lives, drives efficiencies, and generates innovations for health and human service organizations that support our community. MediSked is committed to advancing CMS's 6 pillars, both through work we've done in the past, but so much work yet ahead. And here are some resources that are hopefully helpful. Feel free to download them. They're on the MediSked website. Feel free to cite them, and feel free to let us know if you'd like to contribute, to add, or if anything you find doesn't make sense, or you found information that is complementary. We appreciate it. And the paper that started this webinar.
It's the 6 pillars framework for advancing health policy. What we've talked about in the past hour is captured in an issue brief. You're welcome to download that as well on the MediSked website. You may find the details interesting and provocative.
Thanks, JoAnn. And we'll be emailing attendees a copy of this policy analysis paper, as well as a link to the recording of the webinar. So hopefully it's helpful and you can share. And we work towards the 6 pillars together. So with that, thank you. And we have time for questions.
Thank you.
Thank you.
Hi, everyone. That was fantastic. Thank you both so much for such an informative presentation. My name is Abby Rose Esposito. I am a marketing specialist here at MediSked, so I'll be reading your questions to our presenters today. So feel free to add any questions you have to the questions panel, and we'll answer as many as we can. We do have one so far. Each administration has their own priorities for CMS. What do JoAnn and Doug think about what items to focus on that transcend the administration changes to ensure things are best and most equitable for individuals? That's a good question.
Do you want to say that?
Sure. So we've been at this for about 20-something years and have seen, I don't know how many administrations in that period of time. You always see those items around quality measures and quality care measure, right? The difference between qualitative and quantitative. I think for this particular administration, these 6 pillars meet the moment. They identify diversity, equity, and inclusion. They identify a workforce crisis that 10 years ago was a crisis, but wasn't making it up to one of the CMS pillars. And as JoAnn said at the beginning, the times they are changing. The question is a really good one. what transcends, what doesn't change from administration to administration. And with that, I think innovation, transparency, choice, health outcomes for each person, those are items that hopefully don't change administration to administration. Obviously, this administration has some goals like expanding the Affordable Care Act. You might not have seen that in other administrations, right? So some of this kind of makes sense given the administrations and their policy goals. But hopefully, all of those core pillars transcend, and we can, continue. What do you think, JoAnn?
I think you summed it up really well. I think all administrations want to improve access to care, deal with the cost challenges in public programs, and to make sure that care is of a quality and meets legal standards so that people are not harmed, but actually that they can thrive. I think each administration responds to the times, and we said the times are changing, and this has been, an unprecedented time. And so the pillars reflect priority issues such as health equity. But as we go along, future administrations will be challenged in similar and also different ways. So you might see priorities or where they put efforts. It could change depending on what emerges as public problems and challenges. You would hope that any administration, whether it's red or blue, would respond carefully to the public's needs and cry for better care. Not always more care, but better and person-centered care. And so you could expect that in the future administrations will respond to what are some of the emerging needs as we go forward.
Great, thank you. Absolutely. Well, you must have done a really great job because there are no other questions so far. So thanks again to both of you and to everyone who joined us today. As Doug mentioned, we will be sending out an email with the recording and slide deck and the policy analysis paper in an email to everyone who registered in the next day or so. So definitely keep an eye out for that. Also, after the webinar, you will receive a short survey. If you do have time to complete the survey, it's really short. We would really appreciate the feedback. So if you have any other questions, feel free to contact us. Otherwise, thanks for being here. And thank you both for a great presentation.
Thank you.
Thanks, everyone. So good to see so many people.
Thank you.
Your names, anyway. Thank you.
Have a great day, everyone.
Have a good day. Thank you.